Okay, guys, we're going to get started. I had to stop. There was a train. It's still going by. You're going to hear it in the background. I apologize for that. Welcome to Jonesboro, Tennessee. We have train tracks all over. Anyway, we're going to talk about anesthetics and anesthesia. So it's important. Anesthetics are the drugs that reduce or eliminate pain or depressing the nerve function. And what we're really going to focus on is what you need to understand about anesthesia. If we're given anesthesia, there's an unknown to it, right? So people can be put under anesthesia and not wake back up. And there's really something we're not real sure about. But it is something that we give all the time, and the majority of the people do fine. It's occasionally you might have an incident happen. It is a fear. Anesthesia, there's three types. We've got general anesthesia, which is complete loss of consciousness and loss of body reflexes. And this will includes the paralysis of the respiratory muscles. So if you get general anesthesia, you're going to be intubated and ventilated. You have to be, because you cannot breathe for yourself. So if general anesthesia, we know they're going to buy a breathing tube and they're going to be ventilated because it paralyzes everything. Everything goes to sleep with general anesthesia. Local anesthesia, there's no paralysis of the respiratory function. It's an elimination of the pain sensation in the tissues. And we're just addressing those nerves that are having the actual direct pain. So that, or that area that we want to work on. So we're not giving a general that's going to make everything go to sleep. We're just doing local. And because of that, we don't really have to worry about the respiratory status. We're not going to paralyze the respiratory function. We do want to monitor these patients, though, because sometimes we can give a little too much and it can create issue for the respiratory function. So we want to be very careful. And then we have monitor anesthesia care, local anesthesia, along with sedation and analgesics. So we can do this combination thing to work on people. So we're going to talk a little bit about it. Knowing and understanding that the people that give anesthesia are trained, they're highly trained. We're looking at CRNAs, that's your nurse anesthetist, anesthesia assistants, they're trained completely for that, and the anesthesiologists. So it's not, you will not be given them, but where you come or get involved in this is that you're recovering these patients. You're taking these patients on. Either you're in PACU recovering them straight out, or you get them once they've come out of the recovery room and up to the floor. And so it's important that we understand. We can inhale, we can give volatile liquids or gases. We can, inhale in a general anesthetic. We can give it parenterally, and that is where we administer IV anesthesia. And there are adjunct anesthetics that we can use and give at the same time to get that effect. We see the combo a lot when we're intubating patients. We can give something that's kind of fast acting, but will paralyze everything, and then we can just get in there and get it done. Overton-Meyer theory is the theory that there are two different scientists or individuals that figured out the same thing around the same time, and they kind of come together. And this theory is how anesthesia comes about, how we understand anesthetics. They vary directly with lipid solubility, and we know lipids are fats, right? Fat soluble drugs are stronger anesthetics than water soluble drugs. Nerve cell membranes have high lipid content, so we know. So does the blood-brain barrier. So that's why when we give these fat soluble drugs, they do well with anesthetics, because we're dealing with nerve cell membranes, and then of course the blood-brain barrier we're able to penetrate. And then the lipid soluble anesthetic drugs can therefore easily cross the blood-brain barrier to concentrate the nerve cell membranes. So that's kind of what I just said. But it's just so you know, in general, that the Overton-Meyer theory is how we have anesthesia. Yay! It's like the guy who invented air conditioning. You gotta love him. Anesthesia varies according to the drug. There's stages of anesthesia, but it does depress the central nervous nervous system. It's a progressive depression of the cerebral and spinal cord functions. So that's why it's so important that we monitor these patients, that we have airway management, because if not, we can create an environment that the patient will die. So we've got to be very careful. Let's go ahead and ask a question. I left this question in because I think it's a great one. When assessing a patient under general anesthesia, which change to the organ systems does the nurse expect? We're going to see nystagmus that can occur as a result of the use of general anesthesia. Other findings include skeletal muscle relaxation, hypotension, and increased intracranial pressure. So let's look at that again. So we can get nystagmus, right? We can have skeletal muscle relaxation, hypotension, our blood pressure can go down, and we can have increased cranial pressure. So those are great things to remember about anesthesia, what we can see. Indications. General anesthetics are used during surgical procedures to produce unconsciousness. We want them knocked out. Skeletal muscular relaxation, visceral smooth muscle relaxation. It's a rapid onset, quickly metabolized. So we also use electroconvulsive therapy treatments for depression. So we want to make sure that the patient is down. One of the biggest concerns that we always worry about when giving anesthesia is that the patient is not able to move because we paralyze, but they're underlying awake. So they're feeling, they are feeling it, they know what's going on, and yet they can't tell you what's going on. So we just want to make sure that the patient truly is down. Contraindications, always a drug allergy, always a drug allergy. No known drug allergy. It depends on the drug type. If they're pregnant, we need to be very careful what we're doing and giving. If they have narrow angle glaucoma, acute porphyria, can't even say it, and a malignant hyperthermia. We're going to talk in depth about malignant hyperthermia. Adverse reactions. Sites primarily affected are heart, peripheral circulation. I'm not going to read everything. And we can have myocardial depression is commonly seen. So we've got to be very careful. Let's talk about malignant hyperthermia, though. This is a big one. This is one that you'll see in NCLEX. This is one that we need to know about. It occurs during or after volatile inhaled general anesthesia or use of the neuromuscular blocking drug SUX or succinylcholine. Sudden elevation of the body temperature greater than 104 degrees. So what happens is, so you're going to get malignant hyperthermia. Their temperature is going to go skyrocket. All of a sudden, they become tachypnic, tachycardic, and have muscle rigidity. They're just going to tighten everything up. They're going to become their muscles will become rigid. It's a life-threatening emergency. So let's say these symptoms again. You're going to have a sudden elevation of body temperature greater than 104 degrees. They're going to all of a sudden become hyperthermic. They're going to get hot. Then they're going to become, everything's going up. They become tachypnic. That means they're breathing rapidly. Tachycardic. Their heart rate's going fast, and they're going to get muscle rigidity. They're going to start to have this muscle rigidity. You're going to see it. It is a life-threatening emergency. Treated with cardiorespiratory supportive care, and we can give a skeletal muscle relaxant, and that will help. Okay. In large toxicity and management of overdose and large doses, anesthetics are potentially life-threatening. Cardiac and respiratory arrest, ultimate causes of death in an overdose, and administered always in a controlled environment. You aren't giving general anesthesia up on a floor or even in the unit. They need to be in an OR where they are with an anesthesiologist, a physician, right at bedside at all times. Antihypertensives, we can have interactions that can make them super hypotensive because they're already going to start to be suppressed. So we don't want to give anything else. We don't want their blood pressure to go down any further. And beta blockers, and we'll learn about those soon, but beta blockers will increase with increased myocardial depression. So what's going to happen is you give a beta blocker, you're going to suppress the myocardial contractions even further. So if the anesthesia is doing it, and then all of a sudden you give a beta blocker, we're going to have that we're double dosing there. And we don't want to because we can cause cardiac arrest. During surgery, the anesthetist notes that the patient's heart rate is gradually increasing and becoming more irregular. The patient's blood pressure is becoming unstable, and the patient is starting to sweat profusely. What other assessment should the anesthetist note immediately? And the correct answer here is temperature. Remember, we were talking about malignant hyperthermia. So we've got an unstable patient. That's not good. He's sweating profusely. Sweating is not a sign of being hypothermic, cold. We're looking at hyperthermic, malignant hyperthermia. And so we're going to watch that temperature. These are signs of malignant hyperthermia, which can progress rapidly. It is a life-threatening emergency. Okay, we can give Precedence is a drug that we can give. It is dose-dependent sedation. We can give it to decrease anxiety. And it does not have respiratory depression. You will see it. We give it sometimes for mechanically ventilated patients in the ICUs. We like it because it has a short half-life and the patient can awaken quickly once the drug stopped. Ketamine is a drug I do want you to know or be familiar with. We can administer it IV. It can also be given sub-Q and IM. It has a rapid onset, and it can include some hallucinations if we're not careful, but we have a lower incidence of cardiovascular and respiratory reduction and bowel function. So it's actually a pretty friendly drug, even though some of the effects can be, you can have some other issues with hallucinations and some other things. Nitrous oxide, you guys have heard of it. If you've been to the dentist, it's laughing gas. It's an inhaled gas only. It's used as a general anesthetic, weakest of the general anesthetics out there. So if you're getting laughing gas, it's one of the weakest of general anesthetics. You should know that. Used primarily for dental procedures, and they can use it for supplemental other. Now, this is, we all know that Michael Jackson took that. Remember the whole story with him. We also, it's a white and comes in a white bottle. It's fatty. It is a lipid soluble. It has lipids in it. So this I call the milk of life. It's white. It is something that you give patients. It will take them down. It's parenteral general anesthetic. It'll make them go to sleep, paralyze everything. We can use the ventilator. They can be ventilated. But it is very fast acting. As soon as you turn it off, they will wake up very quickly. But when you turn it on, it also will react very quickly and make them go back to sleep. The problem with Diprivan, the one thing you need to really worry about, it will create a hypotensive state. If you give it, you can bottom their blood pressures out very, very easily. So we want to be very careful. We do have to monitor the triglycerides in it if we're giving TPN, because all of the fats and Ultane is one. I'm not going to focus on that one at this moment. And then we have moderate sedation. Moderate sedation is where we give some medicines, very fast acting. We are not going to, and they don't normally cause respiratory arrest. So it's conscious sedation you'll hear, or procedural sedation. This is where we're going to make them very sleepy. We want to make sure that we have airway by, so that if by chance the patient becomes more sedated than what we would like, and we can assist with ventilation if needed. That is not the goal of this. Moderate sedation is to sleepy, but they don't wake up, they don't remember it, but it does not paralyze the respiratory function. So and they're recovery time, as I said, it's greater safety, has a greater safety profile than you sedation with children a lot too, just FYI. Which statement regarding conscious sedation does the nurse identify as being accurate? The IV route of the drug administration is commonly used in pediatric patients. Called amnesia is common effective midazolam. Patient into tracheal tube, and effects of propofol include relief of anxiety and pain. Is B. Midazolam allows the patient to relax and have markedly open, producing a mild amnesia. The preferred patients for conscious sedation, they maintain their love about it. Propofol, however, pain medication therapy for situations that cause pain response. So propofol, just FYI, it's going to make them go to down for ventilation, but for general, but for propofol, there's no pain relief with propofol. So by just putting them down with in a sedate state, you are not relieving their pain. I'm going to say it one more time. So if I'm giving Diprivan or propofol, I can make them get very drowsy, go to sleep. I can either make them so sleepy that they'll ventilate on the ventilator if they're intubated and ventilating, or I can use it for conscious sedation where they'll maintain their own airway, but they are sleepy and able to obey commands, but just groggy. But if I have anything that I'm doing that can create pain for that client or patient, I need to administer pain medicine along with that, because Diprivan or propofol has no analgesic. It is not going to make the pain go away. Okay. Local anesthetics, they do not you don't lose consciousness with these. You know, we're going directly to where the issue is. So for local anesthetics, we can give it topically, where we apply directly to the skin. We'll do creams. Sometimes we'll put lidocaine cream on before we'll start IVs on patients. That's a local anesthetic. It could be a gel. We can do eye drops, different things like that, suppositories. Parenteral is IV. We're giving it IV and into the central nervous system by various spinal injection techniques. So we can inject it too. So say we're having a baby, right? So we can go ahead and give the epidural or something like that. So we're going to give it directly in. It's specific, but we're not going to sleep. We're not going to paralyze everything. We're not going to need to be ventilated, intubated, and we're doing a local. So the patient's still awake, able to maintain their airway, hopefully without any issues. A little bit of a breakdown of different kinds. We talked about the on-cue pump. I told you about the pain ball, pain busters, nerve blocks. They're all listed there. Here are your canes, types of local anesthesias, lidocaine, bupivacaine, and they just go on down. Procaine, you can just, it's a cane, it's a local anesthesia, okay? So it talks about the paralysis of what happens to when we give anesthesia. So it's interesting. So first, the autonomic activity is lost and the pain or other sensory functions are lost. And last is motor activity. But as local drugs wear off, it's in reversed order. So then motor first, sensory, then the autonomic activity are restored. So we go down one way and we come up the opposite, if that makes sense. We look at this, is just talking about it. Of local anesthetics. I'm not going to read everything, just review that slide for testing purposes. one of the big things here, I do want to talk about this, is you can get a spinal headache. 70% of patients who either experience inadvertent dural puncture during epidural anesthesia or undergo an intrathecal anesthesia, they can get a headache. That's a lot. It's a high percentage. It's usually self-limiting, and the treatment's bed rest, analgesics, caffeine, and a blood patch. Once you've tapped that area, once we've gone into that area, you want to make sure that the patient lies flat. You don't want to just sit them right up. We want to make sure that they lie flat. We can dim the lights. We can give them some analgesics, but the headache can be horrible. They can be in severe pain. If it's so bad and it doesn't ease, that the physician can, anesthesiologist can come and do a blood patch. Just kind of an FYI. That's a good thing to know. When teaching a patient about spinal headaches, which statement will the nurse include? Well, spinal headaches can be prevented with bed rest after the epidural procedure. That is the correct answer. Just so you know, is once the patient has had the epidural procedure, we've tapped into that epidural space, then we can actually have the patient lay flat. Bed rest is think, don't get up, don't raise the head too high, and dim the lights. Just a resting in a bed rest state will help prevent, or if they have a headache coming on, it'll help it from worsening, hopefully. Let's read this. Adequate hydration using IV fluids is often used to increase cerebral spinal fluid pressure. A blood patch is often used to help close up or seal the leak if there is a leak. A small amount of blood is taken from the patient. And injected into the epidural space. The patient should be positioned flat to prevent spinal headache. And if a patient has a spinal headache, relief is often obtained by laying flat. Keep them down. Okay, good thing to know. Lidocaine, we love it and we use it a lot. It can be combined with epinephrine, and we can use it topically, of course. Things on this one. Let's see what we've got. I'm just looking at things really quickly. Sorry. So if we are using neuromuscular blocking agents, what we are concerned with, that's this question, they're going to receive these while mechanical ventilation. While the patient is receiving this medication, the nurses expect the patient to be what? The answer is C, awake but unable to move. If we're using these, they do not cause sedation or relief pain, just so you know. Now let's talk about nursing these. So one thing is as the nurse, if you are using this stuff, we want to know the onset of the action, the peak effect, and the elimination, because you want to know, when are they going to go to sleep? When are they going down? When are they going to have the optimal effect of this medication? And then when are they going to eliminate it so that they're going to wake up and be okay? Our nursing implications are always assess the history. We always look at that and the response to anesthesia. If they've had a history of malignant hyperthermia, then we need to really think about what we're doing here. There's an issue. Assess past history of allergies and medications, and also alcohol, illicit drugs, and opioids. If they have those, they might need to be able to be put under anesthesia. Always vital signs, and you want a baseline lab work and EKG. We're going to look at heart oxygen saturation. You can get remember your ABCs: airway, breathing, circulation, the intra and the post-operative phases. Okay, and then monitor all your body systems. Are they making urine? What's the heart doing? What's the respiratory system doing? You know, what is everything doing? The neurological system, we need to know. Okay. Always provide adequate and informative pre-op teaching for surgical. You know what's going on and what to really expect. Don't ever truth with them. Tell them the truth. If they're going to wake up and they're like, if they're a post-op, come back, they wake up on the ventilator. They have to be able to breathe, take deep breaths in, follow commands before we extubate those patients. They need to know that. They don't need to wake up with a tube down, you know, they're still intubated and awake. It's a very scary moment. So information, correct, truthful, whatever's going to happen, whatever to expect, what pain, whatever, how they're going to wake up out of anesthesia, where they're going to wake up, how they're going to feel. They need to know that. You're going to observe all body systems frequently during the procedure, monitor vital signs and ABCs always. We're looking at vital signs and we're looking at are they breathing, airway? Do they have an airway adequate? Are they breathing? And is their circulation adequate? Always. And you're going to monitor it very carefully. Q15s. You never leave bedside with conscious sedation. You're there, because at any moment things can happen. We're going to watch for sudden elevations in body temperature, which may indicate malignant hyperthermia, which I told you once again is the emergency. It is a true emergency for a patient that has general anesthesia. So we need to really be on top of that. A patient in the ICU will be receiving a neuromuscular block. Which piece of equipment is essential to have nearby when the nurse initiates the therapy? Well, if we're thinking always ABCs, correct? Then what do you think it would be? It's not an oxygen source, because if we're going to be putting them down, they paralyze the respiratory muscles. So it is essential to have a sufficient ventilator support nearby. So we're going to have to intubate these patients. Oxygen alone is not enough. So if it's going to paralyze the respiratory muscles, they have to be intubated. Okay. Okay. During the recovery, we want to monitor their heart, so that if there's cardiovascular depression, we can intervene, respiratory depression, and complications of anesthesia. If everything goes up, they become tachycardic, tachypnic, and if we have that high fever, then these are the big signs. If they're sweating profusely, anxious, those are signs of malignant hyperthermia. Okay. Always reorient your patient to his and her surroundings. Teach the patient post-op turning, coughing, and deep breathing. Teach them post-op. They need to, because we're going to prevent post-op pneumonia. We need everything to wake back up so that they can breathe and everything will be good again. Always reorient the patient, because they're going to wake up and be a little disoriented, and they need to know it's okay. So you might have to do that several times because of, you know, being under anesthetic. That kind of wraps it up. So just remember those few things that I said. Malignant hypertension is huge. We know that general anesthesia takes everything down, paralyzes everything. We know conscious sedation, you should always have oxygen and airway management nearby, just in case of an emergency. If it is a paralytic that's going to take down the respiratory muscles and paralyze those, then the patient must be intubated. And one of the things that we are watching continuously is our ABCs and vital signs, because those are the things that are going to tell us if something's going really wrong really fast. So that will sum this up. If I think of anything else on the next video, I'll add it in there for you guys. So I hope this helps.